Okay, now we are recording now. And so I'm going to start our lecture, PNR 203, week 6. Okay, and today it is on chapter 9, the family after birth. Isn't that nice? We're going to look at entire family, not just mom, but the whole entire unit.
My
All
God.
right. Now, is that a happy time? It should be, right? Should be a happy time. And so, again, let me encourage you to do the key terms. Okay, I say it every week, but do I mean it? Yes, I do. Because you'd be surprised by the time HESI comes around, you have created your own HESI review, HESI concept review. How about that? Okay. All right. So again, let's go ahead and start. Now, what I'm going to discuss today is about postpartum and the nursing care, and for different people, for different patients. Maybe go over a little bit of cultural beliefs that you deal with when you're providing postpartum care and newborn. Now I'm going to tell you a real story. When I was a young nurse, and I learned all about cultures, and my professor told me, oh, no, you better memorize all this. Oh, okay, I'll try anyway. And then so I was taking care of this beautiful Asian family, and I was on postpartum. I was on mother baby unit, and I was trying to get the patient to drink fluids, and I was going, but you have to drink fluids, because I was told, make sure your patient drinks fluids. Okay. So anyway, I'm encouraging her, giving her my spiel. And what does she do? She's refusing to drink fluids. Okay. So her husband walks in the door, and he looks at me and he says, are you trying to get my wife to drink cold fluids? And I said, oh, yes, sir. And he goes, well, she's never going to drink that. I said, oh. I said, well, what should I put something in it, or what can I do to get her to drink fluids? And he says, give her warm fluids. In their culture, they believe in the warmth after delivery for the mom's intestinal tract. So did I learn a lesson? Yeah, I learned a big lesson. What did I do? I didn't have a little Google phone on me, because back then you didn't have Google. And so I went home and opened my textbook, and I went up into that page that teacher told me that I should read. and I became more culturally diverse, put it that way. And so, yeah. So that's why I share that story, because, I know, we go over these things and you go, okay, how am I going to remember all that? Well, you will one day when it happens to you. Okay. So anyway, that's about culture. And then we're going to discuss about postpartum changes in the maternal system and nursing care associated with that. All righty. And then we have to go over some nursing assessments and interventions for a woman who's had a cesarean birth. And, kind of did that in past chapters. I'm seeing that it's kind of repeating itself a little bit. So that's a good thing. All right. And then we go over the emotional needs of a postpartum family and the woman. There's a lot of emotions during the postpartum. And then of course, if she's had a stillborn, we're going to go over again the grieving parent. Okay. So just like I got my camera, I love to see you all's beautiful faces. So join me in the classroom. We're going to pretend we're in the classroom. Okay, thank you. All right, so let's go. So let's start. So another word for postpartum is purpurium. I mean, that's a nice word. I like it. It has a kind of a ring to it. And what that is, at 6 weeks after childbirth. That's okay. Thank you. Okay. And sometimes referred to as the 4th trimester of pregnancy. Because don't we have 3 trimesters, right? And so the postpartum is getting a lot of recognition. Why do you think that is becoming more highly recognized? Just give a stab. Come on. Come on. All right, Farah, since you're right by me on the screen.
What was the question?
Why do you think the postpartum period is becoming more recognized, more in the news?
Is it because there's a lot of, I don't know, there's a lot of, like people are becoming like more aware of it? Like more cases are going up?
Yeah, and what kind of cases? More depression?
Like depression, yeah.
Yeah. And I'm on the TV. Years ago there was some really bad, things happening, and we just kind of like shoved it in the corner and said, okay, we'll be all right. All right. Just like anything else, mental health. We'll just kind of shove it in the corner and it'll go away. No, it doesn't. It just escalates. And so now we're recognizing that, yes, postpartum time is a very special time. And that's when the woman's body goes through a lot of changes. Okay. So now on page 209, and everybody's got a highlighter, or they got my notes, my PowerPoints. Cultural influences on postpartum care. So we're just going to look at that and just know that, back in chapter 6, there was that nice chart on the cultural, and it had all the different cultures in it. You can refer back to that to kind of see, but remember something. If you have a question like on exam or HESI about culture, it's going to be that the nerves is culturally sensitive. And how is a nervous going to be culturally sensitive? All right. And so you want to, just revisit it. And when you're looking at those cultural differences, just think, how could I be more sensitive? Like with, say, a Jewish couple, and they have a little boy. Now, they don't do circumcision on the baby in the hospital or the pediatrician's office. Where do they normally have it? At home. They have a bris. That is part of their culture, their religion. So things like that. The Muslim, there's a lot of, Florida hospital, we had a lot from Muslim country, and they wear what? Their hat, right? The top on their head. And we don't tell them to take it off. No, you can labor with that on and you can deliver. Now, a lot of times they only prefer to have like a woman obstetrician or a woman midwife. But we try very hard to be very sensitive to that and try to schedule them with an obstetrician. But we don't know when she's going to go into spontaneous labor. So a lot of times there was that kind of, we had to jump through hoops to basically get them to have a female, because that's their culture. And their husbands, they turn their back. They don't want anything to do with the laboring process. They'll be in the room, but sometimes they were in the corner, and so they didn't see what's going on. But that's okay. See, and we don't say, well, why don't you turn around? No, we respect that. That's what I'm getting across to you, is that no matter what, you respect that. And I think I told you the story about my patient who was American Indian, and she had a whole big family. Big family. And she said, could my family come in and do a little ritual around my bed? And I said, sure. So they all came in and they surrounded her bed. It was really very pretty. And they all held hands and they did a nice little ritual around the bed. Now, what did that do for my patient? Made her feel good. Think about it. Those little things makes the patient feel really great. Okay. And then again, it shows that I respect them. And that's what we want to come across. Okay. So also, when you have someone that you cannot speak the language, what are you going to do? What do you get?
Get an interpreter.
Interpreter. Yeah, you're going to get interpreter. Okay. Okay. So what happens is that, you know, especially down here in Florida, we have a lot of Hispanic and a lot of women speak Spanish, and they come in, they're ready to deliver. So my Spanish was, you know, a little bit okay, even though I took 4 years in college, a little bit. And do you use the husband as the interpreter?
No.
No. It is very tempting to, believe me, especially when she's coming in and she's completely dilated and she's starting to crown. There's not much time, okay? And so you're very tempted. What we do is we have nurses on the unit that speak Spanish. And what we do is that, but they have to be certified from the hospital in order to be the interpreter, just to let you know. So it's like I couldn't reach over to my friend Yvonne and say, Yvonne, come on, help me out here. She's ready to deliver. Because Yvonne didn't go through the class in the hospital. So there are certain rules you have to follow. And that's one. Even though I'd love to use the husband, we cannot, okay? So if you have a question like that, again, you want to read the question very careful. Okay, and again, what's that question? You want to ask yourself, what's the question asking me? Everybody has that down pat, right? What's the question asking me? It works, guys. Okay, so let's go ahead and talk about the postpartum changes in the mom. So what do you think happens? Well, right now we're looking at the reproductive system, but it affects all her system. The cardiovascular, kidneys, musculoskeletal, because remember, all the physiological changes that occurred during pregnancy is now going to have to reverse, okay? And she's going to feel the effects. Now, the main thing about on the reproductive system is on the uterus. Write down uterus. Because the uterus now has to go through a process called involution. And involution is how the uterus now is going to contract, and you might hear the term afterbirth pains. It has to go through this involution process where now it's going to contract and it's going to go down. So after she delivers, the uterus should be at the level of the umbilicus after she delivers. And then from there, her uterus will decrease, will go down about 1 centimeter per day. Okay, so a lot of ladies after they deliver, they think they're going to have their flat stomach straight away. No. It took a while. Well, it took 9 months to grow that uterus the way you did, and to house a baby. Now you delivered, everything's out. And now the uterus has to involute. So involution is spelled INVOLUTION. Okay. And then another term, if it's a slow process, is called subinvolution. SUBINVOLUTION. What that is, that's the failure of that uterus to return to its pre-pregnancy state. It's called subinvolution. All righty. Now, everything inside that uterus is, remember, we call that the lining. It's called the decidua or the endometrium. All that now that was rich in there to house the baby and the placenta and everything is all what is going to come out. So she's going to have what we call drainage. And that drainage is called lochia, LOCHIA. And for the first couple days, she has lochia rubra, RUBRA. So it's fresh red blood, okay? And it shouldn't have any clots. And unless she's had some more bleeding that she shouldn't have. But it should be, it's called lochia rubra. Now, it will, as it decreases, the uterus contracts, she sloughs off that blood as lochia, and then by, say, the third day, she starts to get lighter, and it goes into lochia serosa, serosa, okay? And then after about a couple of weeks of that, then she'll go into lochia alba, ALBA. So postpartum, that's why we call the fourth trimester, it's not just a couple hours after delivery, it is like 6 weeks. That's why we try to get 6 weeks of, time off. Now, I know some women, they don't take any time off. And I go, oh, no. You got to. Because one thing we want to make sure is that she stays free of infection. And two, their blood pressure. We want to make sure her blood pressure now goes back down to what? To normal. Okay. And we want to make sure that the fundus stays firm. This is where I told the other, I think yesterday in the review, make sure that fundus remains firm. We all know where the fundus is, correct? Is the top portion of that uterus. And I told you that was an important thing to know. And so now, for postpartum time, when you have her on your unit, it's mother baby. And yes, LPNs can work on mother baby units. So you want to make sure that fundus stays nice and firm. Now, let me just add too, that is a great thing when you tell them to, get them to try to breastfeed. Okay. And I try everything I can, because a lot of ladies, no, I don't want breastfeed. No, it's too demanding. Okay. But if you breastfeed, you release more of the endogenous oxytocin, and that makes your uterus contract, and it makes your uterus go down faster. So, I have a young mom, and I say, you breastfeed. Oh, that's very demanding, nurse. I said, yeah, I know, I understand, because the baby eats like every 2 hours, but you can get back in your skinny jeans faster. Do you think she's going to do that? Yeah, I said, those skinny jeans you want to get into, right? And she goes, oh, yes. I go, okay, well, then breastfeed. I do everything I can to get that baby on that breast. And then, of course, she can have 500 extra calories. Oh, who doesn't want 500 extra calories? And then breastfeeding, most ladies do lose a lot of their baby fat quicker. Cause why? Because the uterus is really working. Now, of course, she's gonna have more a little more intense after birth pains. Yeah, you feel it a little more, okay? But that's because the uterus now is contracting, and that uterus has to contract. Now, I want to show you, I love this picture in your textbook on page 210, and that's how to massage the uterine fundus. So in your lab classes, get on your Noel, your simulator, and feel that uterus, and feel the top portion of the uterus, and get your hand and get it like a cup. Okay. Now I do it with not my whole hand, no, and press down, go boom, 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 boom. No, I take my hand and I cup it, and I put it on the top of the fundus, okay? And then with my other hand, I get right here. So like, imagine I have a uterus in my hand, okay? And so I'm like massaging. Now, granted, on some people, I have to go down a little deeper. So I got to go, whoa, okay, I'm going to get that fundus. Oh yeah. All right, come on, fundus. And you see it, and you actually have the person's uterus in your hand. Okay. Now, do I know that the fundus is firm? Yes, I do. Okay. Because nobody bleeds on my watch. That's why I always said when I worked the mother baby unit, oh no, not on my watch. You're not bleeding. Okay. So you cup, and I want to make sure that fundus stays nice and firm. I also want to make sure my patient goes to the bathroom, empty that bladder. Because when you have a full bladder, because the bladder lies right underneath the uterus. When you have full bladder, the bladder is pushing up. What it does to the uterus? It's going to push it back up. Okay, so what are you going to do? We're going to empty that bladder because now she's bleeding more because her bladder is full, and so there's a lot of pressure. Pushes that uterus up. It deviates it over to the right. Okay, and so what happens is that now, where's that fundus? When you go check, you go, where's the fundus? Oh my gosh, it's over. It's not midline like it should be. Is deviated to the right. So now I've got to empty the bladder, and then you get it back into bed, and then you check the fundus again, and sure enough, where is it? It's back where it should be. It's midline and is just below the umbilicus. Oh, good. And guess what? A great side effect. She's not bleeding as heavy. Okay, so that is very important when you take care of a postpartum patient. Okay, and then on figure 9.2 in your book, it shows you how the height of the uterus changes each day as involution progresses. So you can see by day 9, okay, after delivery, it's what? It's way low, okay? And by day 10 now, is now in the pelvic, it's back in the pelvis where it should be. Not bad. Okay. So that is about fundal. If you remember anything from me, is massage the fundus, because those are on tests, and that's a good HESI question. Okay, because they got to make sure that you know that what you're going to do. Okay, and now on page 211, you'll see the definitions of lochia, and you got the lochia rubra, and we talked about that, and we said it was nice and red, and that lasts. Now, some books say 2 to 3, so just know it's in those first few days. Okay, all right, and then you have lochia serosa, and then now that one it's got blood and mucus, so it looks a little more what we call pinkish. Okay, and then that lasts around the 3rd through the 10th day, not a couple weeks, 10th day after birth. And then you have your lochia alba, and that's mostly what? Mucus and maybe some WBCs, and is white, and then that goes to what, the 21st day. Now let me give you an important tidbit here. If you got a patient and you're sending her home, okay, and you know everything right now in the hospital looks copacetic, looks good, okay, you have to let her know that the progression of the discharge is what's going to happen. But the reason why is because I'm sending her home. Sometimes they go home like a day or 2 after delivery. Okay, so it's still having red blood, so they should know that it should change, because say she goes home and it does go from red to serosa, like we talked about, but then all of a sudden a week later is back to really red again. That's fresh blood. So she has to know that that's not normal, and that she has to call, and she has to get back into the hospital, because she could have had a little bit of a placenta fragment still up in that uterus. Okay, and so that is, we have to get that out. Okay, because what's happening is that now the body is trying to get rid of it, and so the bleeding started again. That's not normal. So please write that down, because you could probably see that again. That's a really good test question. It can be a little confusing. So you want to make sure that you educate your patient. When we do discharging, we include that, because I want to make sure she knows that that's not normal and she needs to come back to the hospital. Okay.
Can you repeat that again, please?
Pardon?
Can you repeat it again, please?
Well, I'll try. So what happens is that she has the lochia rubra, you're sending her home, say on day 2. So day 3, she's still going to have some, and then she should get lighter. Okay, it should go to what? Lochia serosa. But
Okay.
say a few more days go by, or maybe a week, and all of a sudden she has Lochia rubra. That's not normal.
Okay.
Okay, because the body has to keep progressing, so downward, so it gets lighter and lighter, gets to alba. So if it goes back to red, hey, something's not right. All right, there's something still up in that uterus that's causing her now to have red blood again. All right, that's not normal. Okay, so that's why she has to understand, because we send patients home with babies after 24 hours. Some of these ladies want to go home right away. They say, okay, I'm done, and I want to get out of here. So then the nurse has to what? We have to do a lot of teaching, because she's going home with all this going on in her body, and it could be very cumbersome for her. Okay, and so we want to make sure they can run a temperature. You can't stay at home running a temperature, 100.4, you start to burn up. What's going on, and it could be the breast that got inflamed. It could be the uterus that got infected. So many things can happen. Okay, does that answer your question?
Yes. Thank you.
All right. Everybody else, please put your cameras on, okay, and join me. I would appreciate that. I'm taking note to whose camera is not on, so please put your camera on. Okay, on page 211, you have a great pad count. Now the pads, you can see, and I tell you, I referred to this, and when I taught on campus, one of my test questions was about pad count. Okay, so I have my bookmarked here. So anyway, just to let you know. And so you can see this is how we chart it. So that's why you have to know how to understand it. Is like scant. Well, scant is only like what? 2 inches. All right. And then you have light, which is 4 inches, and then it goes to moderate, which is 6, and then large is greater than 6. So it's not very hard to remember that. And then when you chart it, you want to chart that when you give a report, when you're giving an SBAR report to your physician, you have to describe the bleeding, because you can't say, well, she's got a little bit of bleeding, or she's got a moderate amount of bleeding. No. That's not quantitative. So you want to describe it and say your patient is having Lochia rubra. The size is 4 inches. Is that a lot of bleeding? Yeah. So what's the doctor going to go? Oh, thank you, nurse. Because when you say 4 inches, he's got that picture in his head on that pad. If you say it's doc, it's like 8, it's like greater than 6, he knows. When you say doc, it's saturated. All right, when that whole pad is saturated, that's how I put it to him. You better get in here because it's saturated, and I believe that she could have probably placenta fragments still up there from the delivery. And they get their butt in there real quick, okay? Because why? Your patient could hemorrhage. And then one of the, put down hemorrhage, because we're going to talk about that. One of the main causes of hemorrhage is uterine atony. So it's uterine, and in other words, according to Cleveland Clinic, it's ATONY. Uterine, ATONY. Now, that is a uterus without tone. Because if you write it out, and you write out ATONY, you can see a tony. Okay, some people call it atony, and that's why I said it that way. In other ways, I said it's a tony is a uterus without tone, because A means what? Without, right? When you put it in front of a word. So it's without tone. That is a major cause of a hemorrhage. Now, another cause of hemorrhage, we talked about it a little bit yesterday, is precipitous labor and birth. when you have that uterus contract and one after another, hyperstimulation of that uterus, the uterus gets what? It gets tired. It doesn't want to contract after delivery. So again, that can lead to hemorrhage because that leads to uterus atony. Okay, you see the connection? So that's another reason why the uterus won't contract. And that's why when you have multiple births, you had twins, triplets, quads. I always think of the Octobomb years ago, the uterus gets so stretched out. And so now the baby's delivered. So now this uterus has got to what? It's got to contract. If it doesn't contract, it leads to hemorrhage. Okay. Everybody, and another reason too, polyhydramnios, too much fluid. What's that doing to the uterus? It's distending it. All right. So that's another cause for hemorrhage, is the uterus gets so distended from too much amniotic fluid, polyhydramnios. Okay. So the nurses, what do you think is the nursing care? What's your responsibility as a nurse? Remember, we're nurses, but we got our nurse's cap on because now we're thinking like a nurse. So if you have this patient in front of you and you come in to assess her, and then you see all this blood on her bed. Now, when I used to do simulation down at the college, I used to have blood all over the place. It was a lot of fun because the students came in and they went like, what do I do? I said, well, you got a hemorrhage. What are you going to do? And so then they had to start thinking what they were going to do. Well, okay, so you got an IV in her. That's a good thing. And after delivery, we don't take those IVs out. If on mother baby unit, we saline lock them. We always want to have access to a vein so you can push meds if you need to. Okay, so we got an IV in her, checking her vital signs. Blood pressure, because blood pressure can go down, heart rate goes up, right? Respiratory rate goes what? Increases, right? What else happens? What else you're going to check? I'm going to check the fundus. Where is that fundus? What's happening? Okay. And then also on the postpartum nurse, as your postpartum nurse, I'm going to know exactly what happened in the labor room. And so if you're working on that unit, you're going to get a complete report when she comes out to your unit. Okay. All right. So I hope everybody gets the drift of what they have to do with the postpartum patient when she comes out to your floor. Okay. And truly, that's another reason why I like my patients to breastfeed when on the mother baby unit, is because I know they're going to get more of oxytocin. Okay. Because that's what happens when you breastfeed, you make more oxytocin, and that contracts the uterus. So that's a good thing. Okay. Especially when you got maybe you're working and you got like 2 patients. All right. But you got 4. And that's really nice. Usually you get 4 couplets. And so how many patients with 4 couplets? How many? 4 times 2 is what?
8.
4 times 2 is what?
8. 8.
8. Okay. All right. Now, other things that occur not only to the uterus, but to the cervix. So remember, the cervix now has been open. It's been dilated. And so the cervix never goes really back to its original state. Okay. When it goes back, okay. And then you have another baby. Each time you have a baby, that cervix kind of gets softer and softer and mushier and mushier. So by the time you have your 9th baby, and you deliver quite quickly because that cervix is so soft, then it kind of mushy afterwards. So each time the cervix never really goes back to its original state, but it will close back up. Yeah. The vagina. So the rugae comes back. Those are your vaginal folds. They disappear, and the walls of the vagina become very smooth, but then they reappear. The rugae reappears about 3 weeks after delivery. All right. So anytime that after you go through like a little section and it says nursing care, read that, because that gives you an idea of what the nurse should be doing to take care of this patient. So in your reading, that's why I love your book, because your reading does really nice. Okay. I usually tell my patients too, when going home, that please try to abstain from any kind of sexual intercourse for at least 6 weeks, especially if you had an episiotomy, because the threat or the exposure, I should say, of getting an infection would be higher. And so we got to keep that vagina, that episiotomy area, the perineum, clean. And so that's why we give her a peri bottle, and she has to, what? She's got to wash off. I mean, she got to use the peri bottle after every time she goes to the bathroom, and pat dries. Okay, now the perineum. Well, what happens to that perineum? Oh, it's stretched out during that labor, right? In delivery. So now the perineum may have an episiotomy. And we talked about episiotomy and lacerations yesterday in the review. But again, you have from 1 degree, 2nd degree, 3rd degree, and 4th degree. Okay. And that 4th degree, it takes some time to what? To heal up. Okay. And so your patient with a 4th degree, now listen up what I'm saying. You've got a 4th degree episiotomy. What are you going to encourage her? Well, she's gonna really feel really scared to have a bowel movement. So we can increase her fiber in her diet. We can tell her to what? Drink fluids, correct? Okay. And then also, we're going to instruct her how to use that Epifoam and that Duraplast. You know, those are really nice analgesics, which do take away the discomfort of that episiotomy. Now, I sent you out some mnemonics. I hope you've been reading those mnemonics, okay? I put that together of all the mnemonics that I come across over the time. And the next one is a great mnemonic. It's called REEDA, REEDA. And that's right on page 213. And this is what we use, because can we remember everything? No, we can't. No. But I can remember this. So R would be what? I'm doing my assessment. So R is what? Redness. When I'm looking at her episiotomy, am I looking for redness? Yep. Yeah. And I want to see how those sutures are put together. Remember I said that surgical cut is easier to heal than a tear? Well, this is where it comes into play, because a tear is jagged, okay? But episiotomy is a straight surgical cut. So there's much easier to what we call approximate, to bring those 2 pieces of tissue together, so that, because later on, guys, she's going to have a life, this is only temporary portion of her life. She's going to have, relations in the future. So we want that tissue to come together and heal really nice. Okay. So it's not bumpy or anything. And so that's what we do. Another thing you're looking for is edema, swelling. Now listen up. For the first 24 hours, you're going to apply ice to that episiotomy. Everybody hear me? Ice. Yeah. All right. Chris, remember something. Ice is your best anti-inflammatory. So what it does, ice will decrease that edema. Because I'm going to tell you, when they come out from L&D and they have an episiotomy, maybe they push for 2 hours, and then they had the delivery, and they have a pee, as I said, and then maybe had a vacuum extractor to help bring that baby out. Is that tissue down there that's so soft and friable? What do you think happens? Yeah, it's gonna swell like anything. So you want to ice on it. So I'm going to look at the edema, and then I'm going to look for what? Ecchymosis. Now, another term for ecchymosis is bruising, and they are bruised. I mean, that, you can't help it. It happens. Okay, there's bruising. It's all according to how big that baby was. Remember, we talked about that, the head being so big that it has to come through. So that's why they had to cut episiotomy. Shoo, you get bruising. But can ice help the bruising? Yep. So this is what you remember: ice for the first 24 hours. And then if you want to do nice sitz bath, warm sitz bath, that always feels good too. Okay. And a big thing about a sitz bath is that it keeps it really clean. And I tell you what, I'm also a wound nurse. So wounds love to be cleaned. They love the water. I could actually look at a wound, and I could actually be like doing wound cleaning, and I can actually see the tissue just saying, thank you, because it gives life. Does water give life? Yeah. So it gives life to those tissues, and it makes it actually approximate even better. Okay. So we got the ecchymosis, and then we got discharge. All right. So on discharge, we want to make sure what? There's no drainage from the what? Episiotomy site. If I see any kind of purulent drainage from the episiotomy site, it's infected. So we want no drainage from the suture line, right? Okay. And then the last one on the red eye for the A is the approximation. And I just told you about approximation. The tissues come together. Okay. And that's all very important. So you use RETA, this mnemonic, to assess the healing or the episiotomy that you're looking at. Now, you only have this patient, the most 1 to 2 days. So I got to use everything I have to basically also teach her. So every time that I'm looking at that episiotomy, I'm teaching my patient what she should be looking at. And how is she going to look at it? She uses a mirror to make sure that she don't get infected. All right. So that's RETA. And any questions about that? And what I do is I teach every time I deal with my patients. I'm teaching my patient every time, because why? I don't have that much time to teach, and she's on her way out the door. All right. So on page 213 is a nice picture of a sitz bath. Okay, so these are nice. These are individual sitz baths, and you just hook them up to the faucet. And I always tell them to have some nice, warm water. And you just turn on the flow, and you basically, she just goes up and down, and really is very, as you can see, is kind of nice. All right. And they go home with it. And so we want to keep going on the sitz bath. And it helps heal, really does help heal the episiotomy faster. All right, moving right along, I have some summary of a nursing assessment postpartum. All right, so we got to look at this patient, and I want you to write down, it's called bubble he. So write down BUBBLE, then HE, bubble he. And what you're going to do is, next to each letter, we're gonna talk what you're looking at. This is your postpartum assessment. So we just did the episiotomy assessment. Now this is your patient on postpartum. And this chart on this table in your book really says it all. Okay. So what's the first B gonna be for? Well, we're gonna be looking at her breasts. Okay. So I want to know if it's soft or in what? Engorged. Ooh, if anybody went through an engorgement time, it's awful. And the breasts get hard as a rock. Okay. And you want to avoid that. So I always tell my patients, see, if you breastfeed, you don't have to worry about that for a while. Okay. Yeah. Okay. Because engorgement is never fun. So you want to look for redness. Okay. Redness in tender areas. And looking for sore nipples. Now, sore nipples is never good, because sore nipples, red nipples, because maybe the baby didn't latch on correctly, and we'll go over that when we get to the newborn. Latching on is very important. They get the whole areola in their mouth, not just the nipple. A lot of ladies just have the nipple in the mouth. No, 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 no. You're going to have sore, cracked nipples. And I tell you, right down, sore, cracked nipples leads to mastitis. And mastitis is an infection or inflammation of the breast. And that is horrible. I know one lady, she had such a case of mastitis when she came into the clinic that underneath, even went underneath the tail of Spence, underneath her arm, that it was all swollen. She came in, she looking like Frankenstein because she couldn't put her arms down. And that lady was in bad, she was really in bad shape. Okay, so we're looking at the breasts. And then for you, we're looking at the uterus. So we already went over that quite in depth. And then another B is we're going to do what? The bladder. So we're going to do an INO and make sure that she's urinating. And then you ask her, are you experiencing anything when you're urinate? And she'll say, oh yeah, I'm kind of burning, and that's horrible. And so burning with urination is never good. And so you want to be on top of that, because what can that lead to? Well, that can lead to cystitis, which can lead to polynephritis, and then you got a sick patient. I don't want her sick. I want her to be able to take care of her beautiful baby. Okay. And then your other B is what? Bowels. Going to look at her bowels. Are you getting this drift that we are looking at this whole body? Yep. Yep. Because she's more prone to what? Constipation. And so you want to make sure that you're listening to bowel sounds. And make sure she's what? Passing gas. Now what can you do as a nurse if your patient says, my stomach's kind of bloated, and I feel like I can't go to the bathroom, and I tell her this is a nursing intervention, is independent. I tell her, get up and walk. When you walk the halls, you hear a lot of tooting, okay? And that's okay. I want to hear those toots, because that means my patients are what? Passing gas. And I tell you what, when somebody doesn't pass gas, they can be in a lot of pain. So we want to make sure, especially if you're putting her, say, on postpartum with iron. Oh, they get so much gas. And then just laying in bed, because oh me, I've got to rest. Okay, get out of bed and walk. Okay. Now we talked about lochia. L is for lochia. So we talked about that and the different characteristics, the amount, and the color. Okay. The next one is for E, is for your episiotomy. And we already talked about the episiotomy. All right. Now, the H is called the Holman sign. Now, what that is, that's discomfort in the calf of the leg. And what happens if they're complaining of pain in their leg, you go down, you assess it, and you see if it's what kind of discomfort it is, and she may dorsiflex her foot, and if she does that and she says, oh, my leg, you have a positive Holman sign. Now that's a indication of a what? Blood clot, DVT. So what are you going to do? Well, you can't just say, oh, you would be okay, Mrs. Jones. No. I'm going to get on that phone to Dr. Jones. And I'm going to say, Dr. Jones, your patient is complaining of pain in her leg. And what he'll send him for is for an ultrasound, a venous Doppler of the leg. And we'll check it out. Okay. Now, thank goodness, a lot of times it's negative. And that's fine with me. But I'd rather be safe, okay? Because years ago, when we used to put our legs up in the lithotomy position, Okay, have you heard of the lithotomy position where it looks like they're in a frog, and they hung in the delivery room until the baby came out, and so they'd be hanging there for a while, and so that caused a lot of discomfort in the woman's leg, and that kind of stopped. That when we stopped those practices and we went to the birthing beds, which was wonderful, then you just had the foot pedals for delivery. So that was much kinder on the legs, because I tell you why. And when you're delivering, and remember I said yesterday, if you've got a head that's stuck, you got to bring her legs. I mean, imagine all the way back up so that everything is like exposed. So tonight on your bed, in your private room, get on your bed, lay down, and try to put those legs up by your ear, okay? And you can see, I mean, you probably don't pull any muscle though, okay? Because I don't want you to pull muscle, all right? But you can see how wide open, all right? So now think you're gonna be like that for a while while we get this baby's head out. And so, yeah, you probably have a little discomfort because you pull muscle, okay? So we had to be very careful though on postpartum because of the coagulation problems after delivery, that you could get a problem such as a DVT. Okay. All right. And then the E stands for emotion. Remember psych? Remember the 4 P's or 5 P's of the labor and birth process? Psych is always in there. And I told you that when we first started, that psych is very, very prevalent in maternity nursing. Has a lot to do with it, because you're bonding with the newborn, and you want to bond with the newborn, and then you go through a process of bonding and then attachment, and mommy has that, and so does daddy. So, and then you're dealing with all kinds of emotions, and as a nurse, we also assess the family interaction, because let's face it, it's very stressful, even on the postpartum floor for a couple, very stressful. And so, they may have some problems. So you've got to basically teach the parents a lot about their newborn. Now, some couples, they never even hold a baby. Maybe they didn't go through the childbirth preparation classes, which was a lot of them. And then you have young couples that now are going to have to hold a baby, and they have to hold the baby so the baby's is supported. So you got to teach them how to hold the baby behind the head and the buttocks. I always said, you got the head and the buttocks, you got your buttocks, you got the baby. Okay. And so you want to always be non-judgmental, teach them so that they know what to do. Okay. Remember, you have to go through classes to get a driver's license. Okay. This is my beef. Okay. You have to you have to go through class to get a driver's license, but you don't have to go through any classes to walk out with a newborn infant. All right. And my goodness, so many babies do get hurt because they're not held properly, they're not fed properly. And so, and while I'm here, I might as well just add this in too. We have safe havens all over. We have in police department, the fire department, hospitals. All you have to do is take a baby there. It's got a sign, it's called Safe Haven. And you just take the baby there and you just hand over the baby and say you don't want the baby anymore. You just hand over the baby and no questions are asked. Okay. And by doing that, creating this, people don't throw their babies in the garbage cans anymore. Because that's what has happened in the past. You just find babies in those big dumpsters. Okay, so it's called Safe Haven. All right, and then and that's why it's so important to teach. And we had classes on postpartum floor. It was so cute too, and they would come like the first day of postpartum, and they would come down their robes, and we had the babies in there, and we went over mommy care and baby care. And it was really nice, but then they decided to take that away and then do it, one-to-one. The nurse now responsible to do it in the room with the mommy and daddy. Okay. All right. So anyway, that's called bubble heat. Okay, so that's kind of a nice way remembering what you're looking at when you have a patient on postpartum. All right, any questions? All right, now let's see. Oh, it's 4 o'clock already. All right, so I'm going to give you a 10-minute break and then come right back. Okay. I'll see you in a little bit.
I have a quick question. I'm sorry.
Oh, no, yeah, go ahead, ask away.
Do you have like a PowerPoint that you like to follow during class or?
Yes, I put that on during announcements.
Okay, okay. All right.
Oh, every week I do that for you.
Okay. I just
Have you
needed
seen
to-
it every week?
Yeah, yeah. I just wanted to make sure that you weren't seeing it and that you were seeing it and we weren't seeing it. Like I thought you would.
No. And actually right now I'm just not even using my PowerPoints.
Okay.
I'm actually just looking at your book and teaching.
Okay, that's fine. Thank you.
Yeah, you're welcome, hon. Cheyenne, how you doing? Are you grasping everything okay?
Yeah.
Okay. Just check it on you.
Thank you.
You're welcome. Let me record. Part of the psychological adaptations is also falls under postpartum blues. Now, why do you think a woman goes through postpartum blues?
Her hormones are everywhere.
Hormonal changes, right? I think I heard hormonal changes. Okay. What's another cause of postpartum blues? How about fatigue? Do they get enough sleep? No.
No,
Are they taking care of themselves? No.
no, they're strictly taking care of the baby.
Right. They're so busy. And it was your first baby. I know when I had my first baby, I was very young and I was like, I never slept. I looked like Frankenstein. Okay. Because they didn't take care of me. I was worried about the baby. And so I wasn't eating properly and didn't have any support. And so did I get blue? Yeah, you get overwhelmed. Wouldn't that be another way to describe postpartum blues? I'm just sad today. Okay. Now, what do you think the difference between postpartum blues and postpartum depression? Carlene?
Would depression last longer?
Yes, depression lasts longer and is more what? Profound. Okay, is much more profound. And so women have a hard time sometimes coming out of that postpartum depression. And that's been on the news a lot. Okay, because they find that women who don't have the support. Remember I told you she needed support during the labor process? Well, she needs it at home. Now, what gets me is I see all these families and they're, oh, boy, it's really getting windy here. Sorry about that. That they get all their family that comes in and sees them, okay, at the hospital. And then when they go home, nobody comes to see her. I don't get it. So usually I tell the family it's very nice that you're all visiting, but right now she's got us up here to take care of her and what she needs and everything. But when she goes home, are you guys going to have a rotation? And that's okay, because I had to protect this woman when she goes home and her baby. All right. And so that's a good question. And we fill out actually a postpartum depression survey. We have you have to fill it out, and we can identify who could have problems going home. Okay, so this is a big area, and we scan for it. We screen every woman before she leaves the hospital with postpartum depression. All right, and you hear it on the news. Yeah, and women get overwhelmed. All right, and just think of a single mom, and she's got to go back to work. So is she really worried about everything about taking care of herself and all that? No, not really. She's worried about the baby. She's worried about, okay, I got to get better so I can get back. I can get to work. Okay. Can you see the psychological problems that can occur during this time? And on top of it, you've got your progesterone and estrogen levels just decreasing, and they're all kind of like out of whack. And it's hard to really focus on what's in front of you. Okay, all right. So I think I got you there. And then of course, if you're always fatigued, and you always don't seem to catch up. So what can I tell her to do? Eat good, right? Eat a well-balanced diet. What? Take her vitamins. You know those great prenatal vitamins that we took while during pregnancy? You can take them afterwards, and get rest. So get your family in the house, come on over and help her out, and so she can get the proper rest. When you get sleep, how do you feel when you get enough sleep? You feel happy? Yeah. Can you concentrate? Yeah. I mean, I know me, I can concentrate much better if I sleep a good 8 hours. So yeah, does new moms get 8 hours? No. Now, breastfeeding. Now this is where it gets on a new mom, it's very demanding. Yes, it's like every 2 hours in the very beginning, because babies' little stomachs are very little, they're just really teeny tiny. Okay, and so if you overfeed a baby, what happens? Comes right back at you. All right. So you can't overfeed these babies. So you breastfeed every 2 hours. Now, if you have a husband or a partner, they a lot of times they get jealous, okay? Because the attention is going all to the baby, and they feel kind of left out. But I always tell daddies, get right in there, okay? And you can help out. Well, I can't breastfeed. Well, I understand that. Okay. But you can change diapers. You can get up, and when baby's crying, you can get out of that bed and go get the baby, wrap him up, and check to see if he's wet. If he's wet, change the diaper, give him to mom. Mom will breastfeed him. And what happens? Then afterwards, baby goes back to daddy, check the wet diaper. If it's wet again, change the diaper, and then everybody go back to sleep. So I said, yes, daddies, you're very important in this process. And a lot of times they can get through it, because a lot of men do get jealous. Okay. And so they all have, excuse me. They all have new roles as a parent. Okay. I apologize. The wind is getting very, very hard here in Orlando. So I'm just going to let you know in case I went, I guess the storm's coming closer. All right. And so we talked about that, daddies, already, but just to go over them, they have 4 phases of adjustment. 4 phases. So let's go over those phases. Basically, they have to go through having expectations and personal intentions. They have to kind of cipher themselves out and say, okay, this is what's happening. They have to confront the reality. I think I talked about this before anyway, but they have to confront the reality and what's in front of them. And sometimes they get frustrated. Okay, they get frustrated. So if you had a nice sports car beforehand, guess what? That 2-seater sports car just went out the door. And now we got the 6-person minivan. Okay. This is happening. I mean, I have had fathers in the postpartum room, and they would go, "Oh man, I guess this is not going to work," because what's your responsibility when you discharge that baby? You got to make sure that car seat, they have a car seat. If they do not have a car seat, they do not take that baby home. All right. So, and years ago, nurses, oh my gosh, we were put to a job taking a patient down, and then we were having to do the car seat. No anymore. That became a big liability over the years. And so now they're responsible. So during the pregnancy, you can tell them they can go to a police department, a fire department, especially the fire department, and they will help them with car seats and show them the proper way of putting a car seat in the car. Okay. And then they have to come out with their own view of their own personal life. This is all this adjustment of true fatherhood. And then again, if they do it the right way, I always say, you do it the right way, guys, you will reap the rewards one day. Okay, it starts from day one. Okay, now we all know that there's some daddies out there that don't even step up to the plate. Okay, but on the majority, it looks good. All right. In your book, it goes over other family members. If there's other children in the household, you have to get that child ready for that new baby coming in. It's going to be a little disruptive because babies cry, don't they? Yeah. Babies need attention, don't they? Right. So we have to make sure that the sibling is ready to accept the baby. And a lot of classes, remember I went over those childbirth classes? One of them was on a sibling class. And that's a really cute class. They dress them up like little nurses and little doctors, and then they show them how to diaper a doll. And so it's really a cute little class. I never taught that class, but I know it's cute. And then again, grandparents. Well, I'm a grandparent. I had no problems whatsoever adapting to this one. I would say, just bring the baby over. You want to sleep? Sure, no problem. So it's a whole different world. And so, but again, everybody's different, and there's different cultures, and everybody has to go through the process. Okay. And then we have, unfortunately, an area in your book is on page 222. It goes over grieving parents. Nothing worse than your baby passing away in utero, or one is just born. Okay, so what kind of communication are you being taught constantly in nursing school? Therapeutic communication. Are you being taught to be a good listener? Yeah. You have 2 ears and you have 1 mouth. You listen. Listen to your patient. Let them talk. And I think that was actually a question on one of your quizzes. Family is important. Privacy is important. Let them talk. Let them grieve. Everybody grieves differently. The old saying is, oh, you have 2 years to grieve, and then you should be done grieving. No. So they go through shock and belief. They go through anger. Especially if you lose a baby in utero, mother goes through a lot of guilt. What did I do wrong? What did I eat? Did I eat the right foods? What happened? And they have so many questions. But what am I going to do? I just listen. And then, the proper time with the non-judgmental and low tone, fuck my patients. It's tough. There's no doubt about it. I've taken care of patients that lost their babies. And one was really tough. I'll never forget. It was a pediatrician that came in at 3:00 in the morning, and she knew me. And so she said, fine, I haven't felt the baby move. I said, oh, okay. So I said, no problem. Let's get you on the monitor. First thing I did, and I couldn't find fetal heart tones. Boy, was I sick to my stomach. Okay. So I said, oh, this is an old monitor. Let me go get one of the new, that was the metric monitor. Let me go get a new Hewlett Packard monitor. Okay. So I'm still thinking, oh God. So I get the new monitor in there and I'm looking for fetal heart tones and I got it from the left side, of the right side. I'm trying to find this baby. There was no fetal heart tone. So she's looking at me with these big eyes and she's staring me down and she's watching my hand moving the fetal monitor around her abdomen. Oh, it was awful. Then I had to get an ultrasound and I got the portable ultrasound in there and there's no fetal heart tone. So then I got one of my doctors up. He was sleeping in the back. It was 3 o'clock in the morning. And I said, I need your help. I said, I got a doctor here that just lost her baby. So he came out and he confirmed it. He confirmed my ultrasound. I tell you guys, it is horrible. And that she was in a high guilt. She was like, I worked too much. I didn't take enough rest. I was doing for my patients. What did I do wrong? I mean, she was coming at me like with everything she could. She needed an answer. But did I have an answer? No. We don't know until the baby comes out and they do an autopsy. And then they find out maybe what happened. But in her case, it was a cord accident. Remember I talked about those cords, a lot of cords? Well, she had oleohydramnios and she had a decrease in amniotic fluid. And so they didn't have enough buoyancy in there. And what happened, it was a cord involvement. Things like that happen. And unfortunately, so what are you going to do? You've got to let them grieve. And at Florida Hospital, we have this little system where we put a little white rose on the door so that patients, people, not patients, but people that are going to come in and clean the floors and stuff, but they don't come into your room and say, oh, how you doing, Mrs. Jones? How's the labor going? Because it's not a glorious time at all. So that's what we do. And we make a memento box. Now, this is always a good question on a test or in HESI. It's called a memento box. And what you're going to do is you're going to ask her, well, what would you like? Would you like me to take a little piece of hair and mount it on the card? Would you like footprints and handprints? Would you like me to take the little bracelet and put it on the card? And so now we're talking, and then I ask her, would you like to hold the baby? And that's what we do. And when the baby's born, sometimes because this kind of condition, a baby had been passed away for greater than 24 hours, the head kind of concaves in, and so you want to wrap the baby up, and you want the hat on so that they can bond. They bond with this baby, sure, okay. And then you ask them if they want any pictures. So it's a pretty tough time, put it that way, okay. But she goes out to postpartum, and you're going to be out there as a nurse on postpartum, and you have to take care of her. And it's the same thing, though. You're going to use bubble heat for your assessment of your postpartum patient, and they go through labor just like anybody else. I try to get them an epidural so that they have decrease in the pain, because a lot of times we have to use Pitocin to induce. It's tough time. Okay, all right. Any questions about that? All right, so everybody's looking at, I gave you all the PowerPoints for this chapter. So I hope you've been following along, taking notes. Every chapter we have discussed, I have given you PowerPoints on, so that you have all the information, and really comes right from your book. All right, let's move on right here to baby. All right, so now we have a baby, all right, and he's been born. So what we call the transition to extra-uterine life. That's what it's called. Extra, E-X-T-R-A, uterine, U-T-E-R-I-N-E. That means they're outside that uterus, okay? That's what it is, outside the uterus. We're born. So, okay, so we come out, and of course, we're going to do the APGAR scoring, and we kind of just went over that yesterday. And then the baby goes through some phases himself. Have you noticed everybody has a phase? Everybody has phases. And so the baby's phase, phase 1 is called the period of what? Reactivity. So when the baby comes out, he's crying, right? And he's looking at mom with big old beautiful eyes, and we dry them off because we want to make sure that they're dry. That's called thermoregulation. Write that term down. And so we make sure that we wrap them up nice, they're kind of cozy and warm. We put a little cap on them because of infants, now listen up, infants lose a lot of heat through their head. Okay, so that's why we put a little cap on their head. That's why we want to keep their body temperature. We want to keep them warm. I've been inside all this time in a nice warm environment, my mommy. Then I'm born into this labor room where it's what? It's air conditioning. It's cold. So now you got to keep me warm. That's why we use a radiant warmer in the room, ready to go. It's on, and it has a nice constant temperature. All right. So that lasts from 0 to 30 minutes, and during that time you have the bonding. Write down that term, bonding. That's an important term, and Hessie always likes those terms. And then we have phase 2. During that time of bonding, and maybe grandparents are in the room, the baby's awake. Now, after about 30 minutes to an hour, baby is now what? I'm tired. Okay, this has been a lot of activity. All right, I have a lot of people looking at me and smiling at me. Okay, I'm tired. I'm ready to go sheepy. All right, so we got phase 2. So you have a decrease in responsiveness. Okay. So this is a good time that we take baby and daddy and grandparents and whoever's in the room. They all can go to the nursery, and daddy can go inside the nursery, because before we leave that room, let me just add this in there. Before we leave that room, what is your responsibility as a nurse? You put the ID bracelets on this baby. This baby does not leave the labor room or the operating room, wherever you're delivering, without an ID bracelet on. So, oh boy, baby gets a bracelet on his wrist and a bracelet on his ankle. And it's got mommy's, it got the sex of the baby, and it's got the time and date, and it's got mom's MRN number. So everybody got a bracelet. Baby has 2 bracelets, one on the wrist and one on the ankle. Okay. And then you got security bands on the baby.
That one goes on the ankle, correct?
Yes, on the ankle. Because on the wrist, even babies are born with fluid, okay? They lived in fluid, all right? So that's why babies, they lose like 10% of their body weight after they're born. It's because when they're born with more fluid in them, because they take all that fluid in. You can't get out. They don't expel all that fluid very quickly. Right after delivery. So that's why they lose. They seem to go down their birth weight. All right. So we got, and so if you have bracelet on the foot, you don't lose it as easily as you could on that wrist. And you don't want to lose any bracelets, because if one bracelet comes off, guess what? Everybody has to have a new bracelet, mommy and daddy. All right. And it goes through a whole big thing. You got to have witnesses. Okay, this bracelet came off. Now this nurse, so Nurse Pamela and I have to witness that this bracelet came off. You get the drift? So you don't want that bracelet to come off. And so mommy gets a bracelet. The partner is it whoever she designates, daddy or whoever, to go in the nursery. That's where the bracelet goes on, and the baby has the 2 plus security. And with those security bands on, it really has decreased those code pinks that we had, code pink drills. They're called code, COEDE, pink. And we used to have drills like all times of the day that we used to, I used to sneak up on my unit and actually had a baby doll in the nursery, and actually was going in and to steal a baby. And so I recognized a lot of problems that I had in my unit years ago, and took care of that. And so, but having those bracelets on now has really diminish that problem. Okay. And all your units, labor and deliveries now are all locked down, and the nursery's locked, and postpartum mother baby is locked. So you have a hard time getting onto these units if you're not supposed to be there, which is good, because these baby snatchers, they were pretty good. They used to come, when we went to regular scrubs in labor and delivery and mother baby, used to have women dressed up in scrubs and just walk on the unit. So it made it a lot tougher now to snatch a baby. Okay, but you have that because some women are just, they just want a baby so bad and they can't conceive. And so this is that, and it was a big problem years and years ago. Okay, all right, so I got the baby now in the nursery. So what are you doing now to mom in the labor room? Okay, so now you're doing your assessment, and you're massaging her fundus, and you're checking her bleeding, and you're emptying her bladder, and you're changing peri pads, and you got her IV yet, and you got your Pitocin through the IV after the placenta came out, because you want that now, the Pitocin to contract that uterus after delivery. Okay, you got the picture? So that's what your role in that room is. Are you busy? Yes, you are. It's a busy time. And so, and I like the family to leave only because I want to clean my patient up. Because mother baby nurses are very, very busy. And so I want to make sure my patient is all cleaned up, ready to go, clean gown. You don't want to take your patient out in a soiled gown and she's been laboring for 18 hours. No way. Make her feel good. When you make someone feel good and you take an extra time, maybe comb her hair and put some lipstick on, she'll feel a lot better. And her recovery, guys, it's unbelievable. Psychologically, you're putting her in a better place. Okay. And then phase 3 is mommy goes to mother baby unit. She gets in her room and guess what? Here comes the baby. And so now they're all as a couplet in the room. So those are the 3 different phases that the newborn go through. Kind of makes sense, right? So everything goes what? You see how nice and smooth it goes in the care? Okay, all right. And so we go into the nursing care of the newborn. All right, so we've got to support thermoregulation. Thermoregulation. And what that is the way baby loses heat. Now, you lose it through evaporation, conduction, convection, and radiation. Those are ways that you lose heat. So what happens a lot of times on a test, they'll give you a scenario and they'll ask you how this baby is losing the heat, through what mechanism, or another way they ask you would be what would be the nursing care. So let's go over the first one, and that's called evaporation. So what happens, babies are wet, are they not? Yeah, I'm just being born, so I'm wet. They're real slippery, by the way. And so they lose the heat through evaporation from the skin. So what are you going to do? What do you do on that? You're going to dry this baby.
Wrap them in a blanket.
Yeah, and I tell you what, you keep those nice blankets, and we have a big old blanket warmer on the unit, and then when you're getting ready to deliver, I have my radiant warmer on, okay? And then I put the blankets on the radiant warmer. So they're nice and toasty, not too toasty, but nice, not very nice. So I'm going to dry the newborn very quickly. And then I told you, I'm going to put the cap on the head because you lose a lot of body heat from the head. That's why there's caps.
Is that after you put the baby on mom?
No. I'm going to put that hat on before I give him to mommy. Now, mommy will take the hat off, obviously. But I want to make sure because the room is cold. Okay, so mommy, now it's all according to how the timing is. Now, listen to me. If you have a baby that's just comes out and looks and doing well, you can do rate skin to skin. Okay, skin to skin. So I can take the baby and put the baby on mom, but I got to dry the baby off. So what am I doing? I am now drying baby while baby is on mom's chest. Okay, I'm drying his head because his head is wet. It's got blood in it. It's got amniotic fluid. It's wet. So you got to dry the head. And then while baby is right there, I put the little cap on. I take any blanket that's wet away from baby. Okay, and I put a new blanket on. Now you can do it that way. Okay, that's called going right from delivery, right out of mom onto her chest, skin to skin. Beautiful bonding time. Beautiful. I love it. Okay, and you can do your APGAR that way because you got to do your APGAR in 1 minute. So I got really good at doing APGARs like upside down. You know, that's okay. I see the baby's color. I can see his breathing. I can see his heart. I can palpate. We palpate the cord. I can feel the heart rate through the cord. You know, I can do all my APGARs right there. I can hit his little foot. He goes, ooh, like that. I got a good reflex, right? All right. Okay, so baby's good. Another way you can do it, if baby comes out, and you can take the baby if mom's tired or mom's not feeling good, then take the baby over to the radiant warmer and then dry him off real quick because again he's losing what? Body heat through what? Evaporation. Okay, so I'm going to go ahead and dry him off, wrap him up nicely and say, mom, are you ready? Okay, so it's all according to the situation in the room as to how, but what am I focusing on? I'm focusing on drying this baby. Okay, so the next one I want to discuss is called conduction. Now, conduction is transfer of heat to a cooler surface called conduction. So what would that be? Well, that would be, let's see, a baby scale. So you're gonna weigh the baby in the room, right? Okay, so I'm going to put this nice warm body on this cold scale. Ooh, that's not good. So what I do, you see those little papers we use on the scale? That's what we use. It helps what? From him losing his body heat through conduction because it's going from a warmer surface to a cooler. All right, that's called conduction. All right, Joelle, you're looking puzzled. Are you okay? All right, okay. And then the next one I'll talk about is convection. Okay, convection. So what do you have? Those convections could be from a draft or, you know, like, you know, down here in Florida, we have air conditioning. Up north, you got like an open window, you know, you get the cool air coming in. But here we have air conditioning. So you can be in a draft. You don't want the baby in a draft. All right. So what are you going to do? You're going to place the crib away from the window or the air conditioning vents. Okay. And then the next one is called radiation. And basically it's a loss of heat to surrounding cold environment. All right. Well, remember I told about labor room being kind of cold, right? So you got walls that are cold. Walls absorb and they remain cold, right? If you lived up north, you would know what I'm talking about is that during the winter time, what? Walls get cold too. Windows. Oh yeah. You put a baby's crib by a window and you got that cold air, you know, coming through. You know, the windows today are much better, but if you have an older home, you can feel that cold air, what, coming right through that window. So these are different ways that babies lose their heat. So the main thing I want you to remember is they lose their heat very easily. And I want you to remember, I went over each one, what you're going to do. So in the delivery room for evaporation, I'm going to dry that baby off, put the little hat on. For conduction, I'm going to what? Preheat my radiant warmer. Have everything ready. And also put that piece of paper on that scale. Would you like to be, when you're a baby, would you like to come out and be put on a cold scale? Ah, no. So put that little paper and you'll help him what? Keep his heat. Babies have a hard time keeping their own internal thermostats regulated. So, I just came out, help me out, nurse, and then convection, I went over. And then that would be just placing that crib away from the window. Don't get a draft. And then you have, what's the last one? Radiation. And the radiation is just, again, you place the crib away from cold walls or window. Okay. All right. So those are pretty important. And I know like Hesse, they kind of like those kind of questions because they usually get students a little bit, riled up about, okay, how am I going to really, really remember this? But if you write down what I went over, that will help you a lot. Okay, so another problem with an infant is neonatal hypoglycemia. And hypoglycemia is blood glucose that's below 45 milligrams per deciliter in a term baby. What kind of baby? Term, T-E-R-M. Okay. Now, babies that are prone to hypoglycemia would be a diabetic mom. Don't forget, you've been feeding me Snicker bars the whole 9 months, and now I'm born, and now you cut me off. How dare you? What happens to my blood sugar? Yeah, takes a dive. Okay. And then if you have a big baby, we call them LGA babies. Large gestational age babies. Large. They're big old babies. I want my sugar. Hypoglycemia. Pretermers can be hypoglycemic and also post-term babies. If I stress this baby out after birth, and it's called cold stress. This baby now didn't get the nice warm blankets that it's supposed to, and it gets stressed out from the cold. That baby, because I'm using all my blood sugar up, because I'm trying to keep myself warm, because I don't shiver as a baby, I am using my sugar. And therefore my sugar, what? It goes down. See how that works? Okay. All right. The next one, if you have a baby that's born with that's hypoglycemic, what do you think they exhibit? It's just like a regular person that's the blood sugar goes down. What do you see? You see jitteriness, don't you? Yeah, the patient, patient, they start to what? Get jittery. Babies have poor muscle tone. They kind of lay there and go, okay, nurse, I'm here, but boy, I'm having a tough time. Low temperature. Babies exhibit something. When they're not well, they have a poor suck. And they have a high pitch cry. High pitch cry. And you'll see that when we get into a lot of the different disorders in the newborns, that poor suck and a high pitch cry are things that you see over and over again. And then, you have a baby that is severely hypoglycemic, you could have a seizure. Yeah. Okay. All right. Now, bonding. I talked about bonding. It is important. So what is bonding to you? Pamela, tell me what bonding means to you.
It's like having one-on-one time with your baby, like
Yeah.
skin contact. Like you're just having time with them, just you and the baby.
Right. Is it an emotional time, Pamela? Yeah, it's an emotional time. And it's a time that's so important to that family for the rest of their lives. Because women who don't have the opportunity to bond with their babies do have problems later on. It's been researched out. Okay. And it's important to that baby because we have people that have problems who are a little psychotic in life who and what are they finding out now? Mental health. They didn't have that bonding with their parents. And so they don't know how to deal with people. And so it's being researched. And I think mental health has come a long way. And then attachment. What's attachment? Curleen. Yeah, Curleen. Yeah, she's going to give me the definition of attachment.
It's something that occurs over time, like when the baby gets used to you. So like they know the mother's scent, they know the mother's touch and everything. So they have like an attachment.
Right. It's a tie, isn't it? I'm tied to you. You know, I know you're my mom because I can tell you by what? Your smell. And I tell you, babies know their mommies because the mommy puts out a certain scent and the babies can pick up on it. And so that it does occur over time. Okay. So that's the difference between bonding and attachment. Bonding is a tie, emotional tie that occurs soon, right after birth. And the attachment takes a little longer. Is a tie that occurs over time. I think it's wonderful how infants know their mommy. Okay, a mom is worried about her baby getting enough milk. All right. So how would you tell her your baby is getting what he needs?
Don't the breast produce what the baby needs?
Yeah,
Like
after
breastfeeding?
after you get into like a rhythm, you get into a rhythm, the breast will so wonderful will produce what it needs to produce. It's really great. Now some women have overabundance, and then those women a lot of times they'll donate their milk to the milk bank, and that's wonderful too. But if you always ask mom, how many wet diapers did your infant have today? And if the infant has, now listen up, this is important. If the baby has at least 6 to 8 wet diapers per day, you're doing good, mom. Did you all hear me? Okay. All right. I hope you took note to that. All right. So, we talked about bonding and attachment, but how would you promote this? Well, we observe, nurses observe this on postpartum. We want to know if the mom calls the baby by name. Okay. If they call it an it, we got a problem. Okay. So you want to do that, holding the infant, talking to the infant, and it's holding the infant, we call it in face, ENFACE. That's a term. You hold the infant in face. What do I mean by that? Holding them and looking at the baby. I had patients that never wanted to look at their babies. Yeah. And they left the hospital without the baby. It happened. And then you're providing skin to skin contact. That's another way of doing initiating the bonding. And then you have the woman talks to the baby. Now I had a patient that right in the delivery room, this couple wanted to have a boy. They had girls at home, lots of girls at home. They wanted a boy. This is before ultrasound, guys. So in the delivery room, she had another girl. She wouldn't touch that girl. She wouldn't bond with that girl. She wouldn't talk to that little baby. She didn't name that baby. I mean, it was serious. And we had social worker had to follow up with them. Okay, because we were worried about that baby. So I often think of that little baby now because it's like 30 years later. Wondering how she grew up. Okay, now breastfeeding. Okay, how we're going. I preach this, and I know I do, but we have to help mom breastfeed. So we're going to show mom the different holes. We've got the football hole, right? And in your book, you have a nice pictures on how to hold and breastfeed the baby. The main thing about I want you to make sure that you understand is that you have to get the whole areola in the mouth. And I talked about that already because I talked about what breast tenderness of mom and sore nipples, because that's what happens. And then mom gets sore nipples, she gets mastitis, and it's bad. And then they get infected. So then they have to pump. If she's on antibiotics, she can't pump out of the breast that is secreting a purulent drainage. That's, you don't want to give it to baby. So you have to pump that breast. And it's usually that's where I lose my patients, is they give up on it. So what do I want to do from the very beginning? I want to make sure. So you could see this question again. So I want to make sure that I'm assessing the proper placement of the baby's mouth on mom's breast. Okay. So mom may say to you, oh, my nipples are getting sore and I don't want to do it. What are you going to do? Well, let's see how you put that baby to breast and I can help you. Okay. And then sometimes too, you put some nice cold packs on the breast, in between feedings, not before the feeding. Oh, no. But in between, some nice coldness, that helps. And then also you can put them in the shower and let the warm water run over it. But I want to keep her breastfeeding. So you want to make sure that you watch that baby on that breast. Okay. And remember, I told you that sucking stimulates oxytocin, and that makes the involution process go faster. Okay, I already went over that. All right. Remember, an HIV mom cannot breastfeed. That virus gets transmitted right through the breast milk. Okay, just want to make sure you know that, because Hesse, heads up, guys, Hesse likes that question. All right. And so I'm going to evaluate the intake of the infant. Infants nurse about 15 minutes per breast, 8 to 10 times a day. That's why it's so demanding. So they feed for about 15 minutes and it per breast, and then you go 8 to 10 times per day. All right. In the beginning, they take in such a small amount too. Sometimes it's like every 2 hours you're on the breast. So like one mother says, that's all I do is lay there and feed. Well, that's what it seems like. If you're ever breastfed, that's what it seems like until you get into a rhythm. And then once you get into a rhythm, guys, is it cheaper? Yeah. Did we go through a formula shortage just recently where they couldn't find formula? And so that's I would be panicking if I couldn't feed my baby. So then when your mommy is breastfeeding, I want to evaluate that this baby is swallowing. So I'm going to listen to the baby sucking. And I'm going to make sure that the baby does a good suck. Okay. And then I want to listen to make sure the baby is what? Swallowing. Because some babies have a hard time, and so you have any problems with the trachea, the mouth, you have, and we'll go into that more when newborn, when we go over cleft palate and cleft lip. Okay, but that's not now. Marie, go ahead and mute yourself, please. All right, everybody. Okay, hang in there with me. It's worth it. And then like I told you, you want to assess how many wet diapers. You got that? Okay. All right. 6 to 8 wet diapers per day. And I know your baby's getting enough fluid. All right. And then an infant passes several stools per day. And one thing about breastfeeding, the actual stools are like yellow and grainy, and they actually smell better. They're like a more sweeter smell than a formula, because babies have a hard time really digesting the carbohydrates that you have in the formula, and they are able to digest easier breast milk. Okay. Now, how do I know my baby's hungry? Well, I bet Farah knows, right, Farah?
Oh, yeah.
I knew my babies were hungry. Well, first of all, my breast said they were hungry. Okay, that's one. Number two is they started crying. And sometimes they have their mouth, right? And they have mouth and tongue movements. They'll let you know. They kick their legs. They let you know, hey, I'm gonna feed me, lady. And so they do. All right. Now let me tell you about breast milk. You gotta know this, is that milk has to be what? You're gonna, if you're going to like save your milk, okay? So you've got to do milk at room temperature. Let me tell you, milk at room temperature for more than 4 hours has a high potential for bacteria contamination. So a container should only have enough for one feeding. So like mom's gonna go back to work, she continue to breastfeed, but she has to pump. But she only puts into one little bottle what is one feeding. And you have to store it. Now this may be another question I may see again. You store it in a glass or hard plastic container. Safely store it in, or you're freezing it. A lot of ladies freeze their milk, but you got to do it in a certain container. It has to be glass or hard plastic container. Okay. It protects what? The nutrients in that breast milk. All right. Don't ever microwave breast milk. Please don't put in the microwave. No, 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 no. Because why? Because it
Kills all the
actually
good
destroys the
bacteria.
immune factors that are in the breast milk. Okay. Do not just take the milk out and thaw it out in, on a counter. You thaw out the milk in the refrigerator. You got to protect the integrity of what's in that breast milk. Okay. All right. Hang in there. Oh, what can I say? I told you already about the calories, so we're good on that. Making sure. Screening test. Let me go over screening tests with you. Before oh, excuse me. Those are my babies now. Before you send a baby home, we have to do a PKU test. Okay. And on page 229, it shows you the screening test and where you prick the baby's foot for the PKU. And this test, it's mandatory, guys. This is not an option to mom. Baby has to be tested for PKU because you're looking for the phenolphthalein. And basically, you'll save this baby and mom a lot of headaches, because this is not good if babies are positive for PKU. Okay, it's a lifelong situation where their bodies are not able to ingest proteins. Okay, so you might want to look at that. And I'll go over that probably tomorrow on the exam review. Okay. All right. And we went over about how to teach mom. And on page 235, there's a good example of the proper latching on. Now I know that's a been a very popular question for Hesse. So you might want to look at that. Okay. How do you break the seal? Now, we talked about babies latching on, but what about taking them off the breast? Do you just kind of pull them off the breast? No, you put your finger in the corner of his mouth and you break the seal. See me? Okay. I'm breaking the seal. And just like that, baby releases. You have to tell mom to do this, because mommies don't know that. They just say, okay, baby, you're finished, and off the breast. No, no, no. So you have to be very careful. Okay, and then you can see at the end of the chapter about storing and freezing breast milk. And that's the end of the chapter, really. Go over on page 244, some discharge. I went over a lot of the discharge earlier when you send mommies home. But make sure that she knows that if she has a fever, 100.4, she needs to call. Okay, she needs to go back to the hospital. She has an infection. We talked about that. We talked about Loki. Okay. And then we talked about how it changes from cirrhosis back to rubra. Okay. And then, oh, she has urinary tract infection. Now, a lot of times they can get that because maybe a Foley catheter was put in and wasn't put in with ultimate sterile technique and she gets a UTI. Any pains or redness or tenderness in the calf, that can be Marley. No, that could be indicative of a blood clot. Okay, pains in the calf. And then you have breast tenderness or redness. Hold on, everybody. Okay. And then you have discharge. If you have pain with a discharge or you have a smell to discharge, remember suture line, you want to keep it clean. So those are things that you have to go over with patient when you're discharging. Okay. And then you have your newborn discharge care. So then you have to go over the same thing with newborn as what they should be, how many wet diapers they should have, how to breastfeed, and the sleeping and their safety, the car seat, all that comes into play. Oh, follow-up appointments with the pediatrician. A lot of times, right from the hospital, we will make the appointment for them. Okay. And so all that comes into play. Okay. And then also, it's all according to, if I have say I have an adolescent who just gave birth. Okay. What am I thinking about? I'm thinking about what we're going to do for birth control. So Depo-Provera is an injection where we can give and should be covered for at least 3 months. Because I've had, now honestly guys, I've had women who left the hospital and had sex within their first week and got pregnant again. And so it can happen. And so you got to be prepared, and you got to have these conversations because you want to make sure that she's covered. Now, if she was not rubella immune, now is the time postpartum that you can give the rubella vaccine. And she can breastfeed with the rubella vaccine. And she has to wait a month. So you have to tell them, do not get pregnant within, 1 month. Have to wait a month. Now, I know, you think, oh my gosh, they just had a baby. But yeah, it happens. So you have to be very honest and you have to have these conversations. All righty. Remember, read the key points at the end of the chapter. And are you doing the unfolding case study? Now, on this chapter, the questions on the unfolding case study, it goes over Rubin's theory of psychological changes during the postpartum. We went over that. So if you do not know, remember that, I want you to write it down and go back into the textbook. What are after pains and why do they often worsen during breastfeeding? Well, we went over that. And then explain how the nurse can evaluate this patient's vaginal bleeding after childbirth and state what the nurse will teach her about what she can expect in the next few days and weeks following discharge. And we went over that. Now, how will the nurse assess the perineum after her episiotomy? Remember, what's that mnemonic? Retta, right? Okay, and then explain phase 2 care of the baby after he arrives in the postpartum unit with the patient. Remember the 3 phases we went over? So they're asking about phase 2. If you don't remember it, what are you going to do? Back in that book. That's what it takes, guys. This is what intensity it takes. And I want you to be successful. Okay, so that concludes today's lecture. Thanks for hanging in there. It was worth it, believe me. And tomorrow, I volunteer to do an exam review. Getting you ready for exam number 2. So I want everybody to really do wonderful. So if you cannot make it to the live session, it will be recorded. All right, I want to wish you all a very happy, safe evening. Those that are in Florida with me, be safe, and hopefully the storm won't be so bad. Has everybody signed in on the chat? Because I look at that for attendance. Alrighty, you all have a nice evening. Bye-bye. Thanks for your attention.
Bye. Have a good
Bye.
one.
Bye.
At the height of where you want the tailgate to go. Simple press again, it will